Okay, sorry, just give me a sec here. More. Okay, so I think we're recording. All right, so welcome everybody to the first SFU Sports Analytics virtual seminar series of the 2021 year. Today, it's my great pleasure to introduce Dr. Doug Richards, who's going to speak to us about injury surveillance in sport. And it's just sort of like I don't want to say like a tutorial type lecture, but he's going to go through the basics of quantifying injury. And it's a very actually rich topic, and one, I think we talk about injuries quite flippantly often in this area. And so to have a proper quantitative background in this area is especially important. Doug has an extensive biography. It's a very impressive biography. So I'll go through it. He's a primary care, sport and exercise medicine physician and a clinical biomechanist. He was educated in medicine and engineering sciences at the University of Toronto and in biomechanics at University of Waterloo. He has worked at the University of Toronto's David L. McIntosh Sports Medicine Clinic since 1984, and he was its medical director from 1989 to 2020. He's been a professor in U of T's Faculty of Kinesiology and Physical Education since 1991, where he teaches courses and mentors students in kinesiology, medicine, physiotherapy, and human biology in the subject areas of sport medicine, biomechanics, and personal health. He was a semi-finalist in the TV Ontario Best Lecturer Contest in 2008 and a finalist in 2009. And I think you'll see why when he starts speaking. Dr. Richards has organized and provided medical services at a variety of national and international sporting events and major games. He has been the team physician and or chief medical officer for many teams and sport organizations, including the U of T Varsity Blues, inter-university sport teams, Canada Basketball Women's National Teams, Volleyball Canada's national beach teams, the Toronto Raptors Basketball Club, and the Canadian Sport Institute, Ontario. His research interests have focused on concussion in sports and the biomechanics of injury. He's also an avid cyclist who rides around 8,000 kilometers per year. He refuses to sit at work, having purchased a treadmill desk in late 2014. So that's very good, promoting physical activity. And he's the very proud father of 2 sons, both of whom are professors, and 3 adorable grandchildren. So Doug, anytime you're out in Vancouver, please, I'll be happy to take you for a spin around these parts. We've got some good riding just east of here. And with that, I will just actually go on to your next, or to the abstract here before I pass it over. So again, today he's going to talk about injury surveillance in sport, and he'll provide a broad sport physician's perspective on the opportunities and challenges involved in injury surveillance in sport. He will discuss measures of injury risk and their components, including definitions and frequency measures of health disorders and measures of risk exposure, focusing on the theoretical and practical challenges in the accurate capture of data about health disorders. And so now I will stop sharing and hand it over to you, Doug, and welcome again.
Thank you very much. If I get the right screen here, you guys can see my presentation now?
I can, yep.
Yep, okay, great. Thank you very much, and thank you for the kind introduction. I have no conflicts of interest in relation to this particular talk. And as Dave has said, I'm providing a sort of a preliminary introduction to this topic from a sport physician's perspective. I mean, I'm not an epidemiologist. I'm a practicing physician for the most part, and while I have had some education in quantitative sciences, I'm not here to talk about the methodology that you will use to analyze data. You have some great speakers coming up in the series who will be talking about that. For example, I'm looking forward to Dr. Schreier's talk, where he'll talk about how methodology applied to the data set that I'm going to talk about capturing. Today, I'm really focusing on the challenges and opportunities in capturing meaningful data that allow us to do injury surveillance. So I grew up playing every sport in the world, all of them badly, as Ian can attest to. I've played floor hockey with him a few times. And I wasn't very good at them, so I went to university where I studied medicine and then some engineering, science, math and stuff. But my practice has been in clinical sport medicine throughout my career, and I've had the opportunity to work with a variety of high-level teams. So I've been in the high-performance sports sector as well as seeing recreational weekend warrior type athletes in the clinic. And I'm now at this later stage in my career, having earned my gray hair, focused on teaching and research and winding down my practice. So why do we want to do injury surveillance? What are we talking about? We're talking about systematic surveillance, of course, of large populations, be they groups of athletes or whole populations, as opposed to individual diagnoses of injury. We're talking about the surveillance of the system. And there are two purposes, one of which actually is right in the trenches, that we can sometimes detect health disorders before athletes approach the healthcare professionals they work with. So a proper surveillance system can sort of get an early warning, hey, there might be a problem here, and then we can go to them and act on it earlier and prevent it from getting worse with secondary or curative interventions or tertiary interventions that improve function while not being able to cure problems. But a larger purpose, and the one most people I think about, is that by systematically studying and analyzing the data that are available on who's getting injured, how often, doing what, under what circumstances, if we can glean some information about causes, Dr. Schreier will talk about that, or perhaps just correlates of disorder, we can design primary preventive interventions in the sport system to reduce the frequency of health disorder associated with sport and physical activity and improve performance outcomes. So those are the reasons that we do it. Now, preventing disorders sounds pretty easy. There are different types of prevention. We can reduce the frequency of a disorder. Sometimes we do things that just reduce their severity. And, ankle braces are a good example. It's been shown in studies that wearing an ankle brace doesn't actually reduce the frequency with which you land on someone's foot when you're playing basketball and twist your ankle, but it reduces the severity of the injury that occurs when you do accidentally step on someone's foot. Some interventions may actually reduce the frequency of disorder, and that's obviously highly desirable. Typically what goes down is that people who are interested in injury prevention identify correlates of risk of injury, and they may be positive or negative correlates. We would prefer to have science that tells us what actually causes the injuries, but that's often not possible. And I won't get into that, especially not with Dr. Schreier on the line here, but you'll be hearing from him about that. And certainly I recognize that in a perfect world or a better world, we would more often identify and have confidence when we make truth claims about what is causing injury, rather than just saying, oh, look at all these factors that are correlated with them. But when you have lemons, you make lemonade, and historically we've had mostly lemons here. We've had observations of correlation of various observable indicators with risk of injury, and so we attempt to avoid those that are positively correlated with risk and embrace those that are negatively correlated. Again, in a better world, if we, a really proper injury prevention program has to go through multiple stages of demonstrating what is causing injury, and then demonstrating that the intervention that's intended reduces the risk, et cetera. And Dr. Schreier will probably get into that stuff more. So risk is a chance of injury or loss in our setting, and it is inherent in all activity. You walk out across the street, you could get hit by a car, right? You can't stay in a bubble, although it's interesting. COVID's given us an interesting perspective on people taking risks, but there's some risk involved in all sports, certainly. And risk management is always a balance between perceived risks and benefits of whatever exposures you're subjecting yourself to. A proper risk-benefit analysis incorporates not only the likelihood or probability of an event occurring, but some valuation of whether it's a good thing or a bad thing. And that value function is a very difficult function to arrive at in our world. In some fields like financial analysis, value is very easy because dollars are dollars. And so, when looking at someone's portfolio and the risks in the portfolio or the risk benefit analysis, you incorporate the upside and downside of various outcomes times the probability of those outcomes, and it gives you an idea of your risk exposure. But in health studies, the value of the outcomes that we're after are very difficult to quantify and so often not used. And people just talk about risk in terms of the frequency of disorder or the likelihood of disorder rather than talking about that likelihood multiplied by some value function. There are some exceptions in that are used in public health, measures of years of life lost, or health or disability adjusted years of life, quality adjusted years of life. Those are attempts to put some sort of quantitative value on getting a particular disease or having a particular disorder in terms of whether it's going to disable you or take years off your life. They are not relevant in a sport medicine world. In sports, the values relate not only to the health outcomes. I mean, I've had athletes tell me when I'm working for the Raptors and telling a guy, well, if you train this much or play this many minutes, you're probably going to be in a wheelchair by the time you're 40. And he said to me, that's okay, doc, I'll be able to afford an electric wheelchair with what they're paying me to play. Who am I to tell him, he shouldn't do that? Because he's the one who's perceiving the value of competing in spite of the fact that it was causing a negative health outcome. It was not only putting money in his pocket, but fame and glory and whatever personal satisfaction he was getting from competing in the NBA. And so it's really the athletes in terms of individual decisions about return to play and risk that they face in returning to play. It's what the athletes think that counts. Our job as physicians is to inform them of the likelihood of different outcomes and have a discussion about the value of the different outcomes, but we're not the evaluators of those. The athletes or other people involved are the evaluators, and the physicians are purportedly the experts on predicting the likelihood of different outcomes, whether you'll lose days of training and miss competitions and so on, are statistics that can be used to quantify outcomes in a system or in an individual injury, but usually when looking systematically at a larger sport population. And you can say, hey, look, because, or I won't get into the causation, but if we can identify factors that appear to be predictive of us losing more competitions, we might want to go in another direction, since winning competitions is part of what people in sports are trying to do. Anyway, measuring values in our world is difficult. So some very basic stuff. I mean, and I apologize if this is too basic, but what is called absolute risk is a population parameter that is the frequency of disorder per specified exposure to risk. And we'll get into what actual measures are used to measure both disorders and exposure as we go along here. I'm going to focus on the numerator today, but we'll talk a little bit first about the denominator, get that out of the way, and then come back to the issue of how we measure disorders. Before I do that, though, a couple of other common parameters or statistics. So relative risk is a ratio of two absolute risks where you can compare one group to another, and it could be comparing a subgroup of a population like children under the age of 10 to the whole population, or it could be women compared to men, or boxers compared to cyclists, or whatever, just different groups. And it's just a ratio of two absolute risks, so it's a unitless number. And one indicates normal risk or the same level of risk for the two populations being compared. Hazard ratio is a statistic that estimates relative risk over a specified study period. So usually in the medical literature, you'll see reports of hazard ratio and meta-analyses and so on, because these are estimates of relative risk based on finite periods of measurement of disorder and exposure. Odds ratio is a bizarre statistic, in my opinion. I always roll my eyeballs when I see it in an article I'm reading. It's related to relative risk and hazard ratio, but it's a ratio of odds. And odds is something that is itself a ratio. The odds of an event being its probability over the probability of its complement. And so then when you take a ratio of ratios, you have to do some algebraic gymnastics. You guys are good at that, and you get the odd ratio for these two things from this formula. Why I'm saying I don't really like it as a statistic is that if issues are either very prevalent or very rare, it sort of geometrically distorts the number that pops out at the end of the analysis, and doesn't, certainly from a clinician's point of view, it doesn't lead to a good gut feel of the level of risk involved. And if talking to an individual athlete and trying to tell them what kind of risk they face, I wouldn't use this sort of statistic, because it would make things seem much worse than they are, or much better potentially. An example for, just to point that out, suppose we look at the risk of concussion in boxing and cycling over a year of participation by 100 athletes. So our exposure is 100 athlete years. In this particular example, and suppose 98 of the boxers got concussed in the 1 year of observation. That's probably an underestimate. It would more likely be 100. And 4 of the cyclists fell off their bicycle and whacked their heads. So they had 4 concussions. Now, if we compute their relative risk, we see it's 98 to 4, or 24.5, but the odds ratio is 4,700. And I mean, you tell me, if you were telling somebody, who's deciding whether they're going to box or cycle, and they're doing so on the basis of the risk of concussion as their evaluator, are you going to tell them they're at 4,000 times more risk boxing? No, I don't think that's reasonable, but their odds are 4,000 times as high as the odds are for a cyclist. So I'll just move along from that. That's just something to watch out for. Back to the question of the numerator and denominator of this fundamental parameter, absolute risk. And as I say, I'll focus on the numerator, but I want to speak to the denominator a little bit. So the denominator is exposure to risk, and we often call those risk factors. It can be just about anything, and historically in medicine and epidemiology and sports medicine, sport epidemiology, prior to the advent of better technology that has facilitated better exposure measures, we were left with things like counting how many athletes attended practice and saying, okay, and those would be called exposures, like a practice was an exposure. So if you had 12 athletes at practice on a day, that's 12 athlete exposures, and you count them over a season. Those exposures are not all the same. Practices and games aren't the same. Not all the practices are the same. When I was in the MBA, we tracked different types of practices, but the exposure still wasn't based on really good quantitative measures of loading or anything like that. It was just how many people attended, and we would differentiate between shoot around practices and scrimmage practices. It's a slightly better definition of exposure to use there, but many exposure variables use duration of exposure. So they talk about the hours of participation, but again, all the hours of participation are not the same. An hour of shoot around practice is not the same as an hour of a game. And so these are on some level pretty crude measures of exposure to risk, but they are the ones that have historically informed most of the literature on the likelihood or frequency of injury and risk of injury. The advent of technology really is just opening up a world of opportunities for using better quantifiable measures of exposure to risk of damaging tissue or injury, and measures of training load. You're going to hear about stuff like this from a number or several of your speakers over the series. Include measuring how far did people run using a GPS tracker, or how fast they run, what their average velocity was, kinetic variables, force or moment sensors, measuring, and you'll hear like in Dr. Jordan's talk, great work looking not only at forces and moments, but at rates of force or load development, and some very detailed kinetic measures. And if we have wearable technology and athletes are wearing all this kind of stuff. Kinetics are hard to do. Kinematics are easier with the wearable sensors, but you can really start getting a much more accurate picture of how hard the athletes are working, and physiological variables like heart rate and so on, all kinds of stuff. So the world is the oyster out there, and I'm not going to talk a lot more about this, but I think that as we use better measures of exposure, we'll get better information out of the system. I have one pet peeve in this regard, and that is that you know, all of those things I just talked about, these quantified measures of training load and so on, are very focused today, at any rate, in 2020, on issues of movement quantity, as opposed to movement quality, by which I mean things like skeletal alignment, both static and dynamic alignment of the skeleton and joints during movement, the balance of muscle forces that result in net moments at joints, and different kinetic solutions for the same kinematic outcome. Those issues of movement quality are very difficult to measure, not impossible, and technology will increase the likelihood of being able to measure them, like say to be able to dynamically track someone's skeletal alignment while they're playing is not out of the question. It's certainly not possible, or not easily possible today. And yet quality of movement is, in my opinion, as someone who's been in the clinical trenches for 40 years, an exceedingly important variable in predicting the risk of whether or not, say, running is going to cause patellofemoral pain. Yeah, the amount of running and the speed of the running and all those kinematic and quantities, they tell you something about the risk, but how well the person runs and whether their hips are adequately controlling the alignment of their lower extremities when they're running, that's probably as important or more important than just the amount of running or the rate of progression of the amount of running. So those issues of movement quality are something that don't get enough attention at the present time, in my opinion, but hopefully will in the future. I was introduced to Sutton's law early in medical school. You know, when you don't know what you're doing, you use heuristics. And medicine is full of heuristics. Anyway, Willie was a bank robber who, when he was asked why he robbed banks, was sort of like, duh, that's where the money is. Of course, why wouldn't I, you know? And in medicine, we use Sutton's laws in heuristic, where we say, go where the money is. In other words, focus on the most, the things that are most likely to yield results. Yes, there may be a 1 in a million chance of some rare fatal thing, whatever, but you know, there's a much bigger chance of this. So let's focus on this right now. And so the question is, in the world of measuring all these different types of exposures in the denominator in injury surveillance, where is the money? And this table shows by dint of the size and color of the font where the money is, not just from my perspective, but you know, there's a body of literature, and I'm not going to go into all the evidence. I can send references if you like, where first of all, we see different types of injuries in sports. Some of them are what we call acute trauma, where there's, you know, a collision and there's violence and boom, someone's injured. And I mean, it doesn't have to be a collision. It could be that someone lands badly from a jump and their knee dislocates, and that's acute trauma, a single repetition of violence. But often we apply loads repetitively and have injuries that build up gradually. They're called overuse, and I have that in quotation marks because it's not necessarily the amount of stuff that counts. If we just think about all the things we could measure, issues around the quality of movement or physical activity, and issues around the quantity of movement or physical activity, and look at which ones of these are the most important determinants of the likelihood of these events, there's absolutely no doubt that the most important determinant of the likelihood of acute trauma is what activity you choose to do. If you attempt to climb the north face of K2, I think the fatality rate is 20% or something like crazy like that. Like, you know, if you fight with the bulls, you're going to get gored. If you box, you're going to get hit. If you play rugby, you're going to collide with people, and so the likelihood of acute trauma is in large part determined by that. Well, that's not something you can control, and if people want to do those things, they want to do those things. So it's not a system factor that we're necessarily going to change. I think individuals use it to decide what activities they might choose to take up or have their children take up, et cetera. The other issues that determine the likelihood of acute trauma, movement technique is critical. And this is where I'm talking about the quality of movement. And it's not something that's often tracked. But I mean, it's looked at in research studies, but it's not usually tracked in large scale injury surveillance systems because we don't have good input on how well people are moving. But the other issues involve the quantity of movement. And in terms of quantity, I've identified three things here, and these are very high definitions. We could get down into the weeds on them. In physical activity, and this goes against all my training in physics, we call the product of power and time volume. I mean, that's work, people. It's energy. The amount of physical activity you do can be measured by the amount of energy expended if you measure the energy per unit time times the time. But when people talk about physical activity intensity, I mean, really you are talking about power, energy per unit time, but there are other measures of it too, such as forces involved and so on. So we use these airy-fairy terms, volume and intensity, to describe a category of variables that are related to, in the case of volume, the total amount of work done or the total amount of activity engaged in, versus intensity being either power or force or some measure of how difficult the activity was, I suppose. And in terms of the likelihood of acute trauma, the amount of activity is probably not as big a predictor of risk as the intensity of the activity or the rate of progression of quantity. And what I mean by there is, okay, you may play 2 hours of tennis a week, but if you play 2 hours of tennis a week for 5 years and then suddenly start playing 6 hours per week, you may increase the likelihood of something happening acutely. When we look at overuse injuries, technique is again an important variable, very important. Type of activity perhaps less important. You can get overuse injuries doing anything from tiddlywinks to swimming to climbing mountains. But the one that really jumps out of the literature that's become available over the last decade or so is that it is the rate of progression of the quantity of activity that is a significant predictor of risk, probably. And studies have shown, for example, that the amount of exercise that you did this week is less predictive than a comparison of how much you did this week to how much you did over the last month. In other words, it's not the volume of activity this week, but the rate of progression of volume and or the rate of progression of intensity. So these are things that get a lot of attention. And the current version of load management, and load management was certainly not invented by Kawhi Leonard or the Toronto Raptors a couple of years ago. I can remember telling, we had one athlete on the Raptors when I was there. He was only allowed to play 19 minutes per game, and we had a stopwatch on him because if he played 20, his knees blew up. He didn't like it, but the coaches and everyone were like, no, we don't want his knees to blow up, so we keep him to 19 minutes a game. This is kind of different, and the Kawhi Leonard version of load management, that's managing someone's volume of activity to prevent exacerbation of an injury as opposed to preventing one in the first place. But the literature has shown, and so sport organizations are now have widely adopted load management systems that track their training load using some sort of kinetic or kinematic typically, or kinetic or physiologic measures, and then limiting them to a progression based on the formulae from Gabbett, Blanche, Williams, and others. There are different statistics available: the acute to chronic workload ratio, the exponentially weighted moving average. They're all statistics that really indicate a ratio of how much you're doing now to how much you've done over the last month or so, and they're very valuable in this field. So enough about the denominator. You'll hear more about that from some of the other speakers you have, and if you are involved in the real world with a sport organization, you'll certainly get involved in exactly what is it you're tracking in terms of exposure. That's the denominator. Well, the numerator is a measure of the frequency of health disorders, and I want to talk about what that means, but especially not so much frequency measures, which you people are probably familiar with already, but exactly how do we decide when we say, okay, you have this problem? How do you diagnose a disorder? How do you classify it or code it? And how are those captured in information systems? The most common measures of the frequency of a health disorder are its incidence, which is the number of new cases per specified time period. And I guess these days with COVID, I could have updated my slides here to use a COVID dashboard as the example. You can flip from looking at, daily new cases to cumulative new cases to active cases. Active cases, really, prevalence is the total number of cases of a condition in a population, either at a time point or over a specified interval. And, in the case of looking at COVID, you might subtract the resolved cases from them as they come along. So you've got the incidence of new cases coming in, but as people die or their cases resolve, the number of active cases at any point in time would be the prevalence of the disorder in the population. The World Health Organization says that health is a state of complete well-being, not just the absence of disease or infirmity. There's two important points here. One is that there are multiple components in health. I'm not going to beat that to death right now, but I want to point out that it also implies, for me anyway, that in order to be healthy, you have to have not just an absence of identifiable disorder, but you have to be able to live and enjoy life. You have to have some capacity to do whatever it is you want to do and to function. And in my world, in the world of kinesiology, we call that fitness. Now, that's physical fitness, and there's also psychological and cognitive fitness and all that kind of stuff. We don't typically identify deficiencies of fitness as health disorders because the health care world is really a disease care world. It's interesting, we call it the Ministry of Health. The Ministry of Health has nothing to do with health. It manages disease. Health is promoted by physical activity and good nutrition and things that the world of disease care is not necessarily directly involved in, and that come from other things like the government making bike paths for us or whatever else they can do. There are social interventions that give us better fitness and performance capacity. Anyway, I'll move on from that. A health disorder in this disease-focused world is really any phenomenon that detracts from this wonderful nirvana, this state of complete mental, physical, and social well-being. And that's a pretty broad definition. But to detect that such a phenomenon exists, there has to be some observable indicator of it or manifestation of disorder. And not all of the indicators that we use are objectively observable indicators. When someone says, I have pain, only they can feel their pain, despite protestations from their friends, their empathic friends who say, I feel your pain. We have to trust them. We can ask them to try and quantify their pain on a visual analog scale and whatever. But I mean, it's really not an objective observable indicator, but it is an indicator that we use. When healthcare professionals themselves observe things directly using their senses, we call those clinical signs or sometimes clinical tests. And then we have learned to extend our sensorium. I can only see visible light, but if I send you to the hospital, we can use electromagnetic radiation of various frequencies like X-rays and radio frequency to do MRI and take imaging. We can look at people on a molecular basis using blood tests and tissue biopsies and whatnot. So all of those indicators are manifestations of disorder. And as soon as someone has an indicator that is abnormal, someone is going to label it as being a disorder. Now, okay, fair enough. there are different types of disorders. This is non-technical, but just so that we're using the words the same way. Really, disorders that are caused by energetic violence of some kind are called injury, whereas all other disorders, they're called diseases or illnesses. If you're electrocuted, you don't say you have a disease. And if you've torn your ankle ligament, you don't have a disease, you've got an injury. That seems like fairly normal English. We also have some disorders where we're unable to identify structural issues. I'll talk about that a bit more. And so we really just specify the disorder by saying, well, here are all these manifestations of dysfunction, these abnormal variables, and that's a disorder. Diagnosis is to distinguish between different disorders, as it were. And you can get really philosophical here and say, well, if any set of manifestations that are abnormal is a disorder, what do you mean? Well, what I mean is that some of the indicators that we use are indicators of structural abnormality, where like an X-ray that shows a bone is broken, or a surgeon inside someone's knee who can probe the ACL and demonstrate visually and mechanically with their probe that the ligament is not intact. Or if I see you bleeding from an open laceration, I mean, I can see that you have a structural abnormality of your skin. So a pathoanatomic diagnosis specifies what anatomy is deranged and exactly how it's deranged. Is it ripped asunder? Is it swollen? Is it, neoplastic, like a tumor? What is going on? Those are pathologies. And then we can specify cause. Well, really, are we doing that? What we're doing is we're saying we've observed indicators that we believe infer cause. For example, if someone comes in with a sore throat and I can culture Streptococcus pyogenes from the back of their throat, I'm assuming, not really, I don't know, but I'm inferring that the streptococcus in their throat is what caused their throat to be sore. Sometimes it's very obvious. If you see someone hit by a car, or when you're watching sports, you see a collision, it's a good bet that the mechanical violence of that collision is what it caused them to have a sore knee. But really, we're seeing indicators, and some indicators are indicators that imply cause, as opposed to indicators that imply abnormal structure. When we don't have any indicators that imply abnormal structure and or abnormal cause, we're left with just manifestations of disorder that specify abnormal function or abnormal values of variables compared to normative distributions, and that's called clinical diagnosis or diagnosis by syndrome. When we want to code a disorder in an information system, we use these coding systems that are out there, and all of them are flattened multi-axial ontologies. And by that I mean that, a proper diagnosis, and I very much support what the American College of Pathology says on this. Way back in the 1960s, they said anyone practicing pathology, which, from, CSI and whatever, is the people looking at dead bodies and diagnosing them after they've expired. But nonetheless, to specify a cause of death fully, or to specify a pathological disorder fully, a pathologist has to sign off on three things: what caused it, what anatomy was involved, and what the microanatomic nature or the pathology, the tissue morphology or whatever was that was observed. And if you specify all three of those separately, you have a complete diagnosis in their system. Well, the systems that are used, the ones that I've got listed above there, ICD and Calgary and Orchard, they dabble in all of these, and then they specify all of them to some extent, but not always. So it's not sort of systematically enforced, and sometimes they conflate the different indices or axes, and it causes some problems, in my opinion. Unfortunately, electronic medical records in Canada and United States still, well, in the United States, many of them use SNOMED. fewer in Canada. Certainly in Ontario, ours, in order to bill OHIP, we use ICD-9, which is just a god-awful system and not good for sport medicine or much else really, other than getting paid by OHIP. But if you're relying on information that's in a doctor's or therapist's medical record system to detect the frequency of disorder, you've got a problem right off the bat because of the coding system that they're using. In sport information systems, databases that sport organizations use to monitor injury rates and to track training loads and stuff, most of them use the more sport-related coding systems, the Calgary or Orchard systems, if they use any structured system at all. The Calgary and Orchard systems, which have been the two most widely used coding systems in sport medicine, have recently been revised, and a consensus statement sponsored by the International Olympic Committee Medical Commission published in the British Journal of Sport Medicine in February 2020. So Winnie Moise from Calgary and John Orchard, I think he's from Australia, and they are some of the original authors of the Calgary and Orchard systems, obviously. They've harmonized them a bit. They're not fully harmonized. They're still different. And the consensus statement says, choose your poison, use one or the other. I guess they couldn't, get together fully. They're very similar, and it would be possible to combine data from systems that use those two different systems, but it would be some work. You'd have to do some manual massaging to, code them in a unified way. Nonetheless, they're the best available ones that are out there for sport medicine these days. The problem is they're not found in electronic medical records, with a few exceptions. I know in Alberta, they allow doctors to use the Calgary codes and get paid. We can't do that in Ontario. We're stuck with ICD-9 in our system. So if we want to use Calgary or Orchard, it's an extra step in the workflow. It's more work for whoever's involved, and it's often very difficult to get those people to do it. So we have real world deficiencies, and I just alluded to one of them there. And they're not all theoretic, some of them are, but just a failure to capture data, number one. Where, if the athlete's not reporting that they have a symptom and it's not objectively observable, there's no objective manifestation of disorder, their disorder is just not going to get captured, period. Redundant capture is caused by bad coding systems and so on, where you go and automatically retrieve the number of, encounters related to knee injury, and without distinguishing that multiple encounters were related to one knee condition, because the way they're encoded in the electronic medical records, it just counts encounters. It doesn't count problems. And that's a problem, that we're not actually tracking the number of disorders in our electronic medical record systems. We're tracking the number of encounters we've had typically. You've got highly skilled observers making diagnosis and often less skilled ones, or observers like just people saying, I have a sore knee, with no training or understanding about what was causing their sore knee or what was pathoanatomic about it. Access to healthcare for accurate diagnosis varies in different parts of the world and different parts of the country even. And for athletes at different levels of sport. And many sport organizations, certainly at the national level, have athletes who are not a very captive population. Like with Canada Basketball, we get together for summer training camps, but then the women are all around the world playing in WNBA, Europe, Australia, you name it. And so trying to get and capture data from all of their healthcare providers in all of the different settings in which they play and train, that's really tough to do. And because we're not all using the same system, even in Canada, let alone around the world when they go and play elsewhere. You can define disorders differently. I touched on that a bit briefly, but aside from that, the threshold for detecting it, like we could define, a torn ankle ligament as an ankle ligament that is structurally ruptured, but how do you detect that? Are you detecting it by clinically examining someone's ankle, by doing an MRI, or doing surgery and observing the tissue directly? Those different diagnostic thresholds will result in different measures of disorder frequency in the same population because of the detection threshold. And then I just touched on the diagnostic classifications and codes used in different EMRs and sport information systems. So often at the end of the day, you people are the people who are charged with analyzing the data, and the data set you're going to be given is going to have bushels of apples and liters of orange juice in it. And there's often a lot of, I say this euphemistically, cleaning data up, quote unquote, before you can do analyses because of the different ways in which the data was captured and the deficiencies in the data set as a result of that. In terms of workflow, a lot of organizations now use electronic questionnaires that are sent out even on a daily basis because people have smartphones and apps for this stuff. So the athletes do sort of a daily, how you feeling today? I feel crummy. I didn't sleep well last night. They answer wellness questionnaires like the Hooper McKinnon or other things that are just sort of general indicators of their vitality, their energy level, how well they feel, how they're sleeping, things like that. And if something comes up, or if they say, I have a sore shoulder, I can't train today because I can't swing at the ball, a flag pops up on the screen of a staff person, usually the IST lead, who is designated to follow up on flags. And so this diagram, courtesy of Ryan McDonald, who's the IST lead with Beach Volleyball Canada, every athlete in the system completes these questionnaires daily, and they've got great compliance of it. So he knows right away if someone didn't sleep well, or if they had diarrhea, or whatever. And then the question is, well, what's he going to do about it? He decides whether or not it requires, further assessment by another person in the IST, et cetera, and then at some point, information gets put into, after there's been a response, maybe they've seen the doctor, maybe they haven't, someone enters data into Smartabase, the system that Ryan's using to track. It's the system they're using to detect that there's a problem in the first place, but then it's a system he goes back and, using a code like an Orchard code, tries to put in what is wrong with the athlete. The problem I have, and I've talked to him about it and we're working on this, is that often these things wind up getting put in the system without the problem having been thoroughly evaluated, and the quality of the input there is highly questionable in many cases. The group, the Oslo Trauma Group, which is a famous group that's done just tremendous work in injury surveillance and other things, they identify that and show that the responsibility for registering a diagnosis in the database is not something that is left up to the athlete or even the physiologist who's the IST lead. It's the medical team's job. And if the weekly questionnaire results in a yellow flag that says this person needs to be medically evaluated because their wellness indicators are in the yellow zone, or forbid the red zone, we need this medically assessed, then it's explicitly the job of the medical person to put that information in the sport database. And that's a missing link in most of Canada in our sport systems, because when someone goes to see the doctor registers their diagnosis not in the sport database, but in the electronic medical record, and the two don't speak to each other. Believe me, we're working on that and working with EMR vendors and sport database vendors to try and find solutions to getting them to talk to each other, but that's much easier said than done for a variety of real world reasons, most of them involving money. I should skip this slide with Ian here. I just want to point out that, so now you've got a big data set with a bazillion indicators, some of which are measuring exposure and some of which are measuring dysfunction, and go at it. Please attend Dr. Schreier's talk in February, and I will be too. Trying to actually determine what is causing disorder is a holy grail here, perhaps achievable. We'll wait and see what Ian tells us, but it's not what I'm focused on here today. So today, what I've tried to share is that the explosion not only of computer science and information technology, but of measurement technology in physical activity and movement, measurement of kinematic, kinetic, and physiological variables, provides us with an amazing opportunity to increase our understanding of and to more accurately capture injuries or disorders associated with sport and what is causing them, or at least what is correlated with them. But we do have a lot of challenges, and what I focused on today, because I think, well, you know, right from the start, you guys know your data scientist, garbage in, you're going to get garbage out, right? So looking at how a sport organization is capturing data and trying to make it as little like garbage as possible is an important task. And you know, these issues that I've identified, failure to capture or redundancy of data capture, different observers with different thresholds and diagnostic standards, distributed care, and perhaps the biggest plague, and this is really a software engineering issue as opposed to a data analysis issue, is getting the IT systems to talk to each other in a way that we have a workable data set at the end of the day. And by different information technology systems, I'm not just talking about, you know, Edge 10 used by wheelchair basketball versus Smartabase used by beach volleyball, because all the different Canadian high performance sports are using different systems, you know, on the sport side of things, but then all the healthcare providers are using different electronic medical record systems, and with very few exceptions, those two worlds don't talk to each other. So it requires a redundancy of data entry. And trying to get a physician to enter the information twice in two systems is a really difficult task. If you pay someone to copy and paste from one system to the other, you can get it done. But again, physicians who are, you know, doing it for a living are not likely to want to pay people to do that. And to date, most sport organizations, this is changing slowly, but historically in Canada, not at pro team level, but at the Olympic and Paralympic level, you know, they've not invested the money required to facilitate redundant data entry. Obviously, better than manually entering the data twice, even with copy and paste functions, would be to get the two systems talking to each other and sharing data automatically. And that's a project that I'm aware is ongoing, both in the high performance sports system and at University of Toronto. We think we're very close to having an agreement with two vendors that are going to help us marry our two systems. Fingers crossed, but touch wood on that one. And then I won't get in, again, Ian will be talking about actually attributing risk of disorders to exposures and attributing athletic outcomes to the existence of health disorders. That requires some data analysis and causal inference, and you guys will look at that more later. So I think that's it for me now, and I'm really happy to take any questions if you have them.
Great stuff. Thanks very much, Doug, for a really great talk. So I'm going to open the floor to questions. I think let's start with posting them to the chat form if you have a question. And as we go through, we'll probably just open it up to everyone to do by voice. But I'm going to start with a question that was posed in the chat form from Josh Gorham. So Josh, please be ready with your microphone to communicate with Doug if you have to. He says, thanks for a great talk. Just curious, so what do you think, Dr. Richards, is the biggest hurdle to measuring technique is? You said that there weren't good inputs when talking about the issues of physical activity. I assume he means data. What does he think the solution is? How do we improve technique measurement?
I think the two biggest issues in the technique or quality of movement as they relate to risk of injury are, well, they're motor control issues. How well can you control the segmental masses of your body in three-dimensional space given gravity and inertia? And, you know, so it's a biomechanics problem where skeletal alignment is critical because that's going to affect load distribution across joint surfaces at articulations. And so you can observe skeletal alignment with three-dimensional motion capture, but it's, three-dimensional motion capture is not feasible in all practical settings. At every basketball practice, you haven't got full mocap on everybody. To the extent that we're gradually approaching markerless motion capture systems that are based on just multi-angle videos, like if you've got, video cameras at least 3 orthogonal angles, you can do some analysis of segmental alignment, but it's, it's getting there, but it's still very difficult. It's still very labor intensive, technology intensive, and post-processing intensive. A lot of work goes into doing mocap analysis after the fact, especially if it's markerless from video, and doing that for every athlete in every practice, whatever. It's a challenge to do that. If there was some way, for example, when I was a grad student in biomechanics, we used radio frequency transmitters and receivers to track the movement of the lumbar spine in Stuart McGill's lab, where we'd attach one transceiver to the thoracolumbar junction, another one to the sacrum, and these two things could then detect their relative position in space in 6 degrees of freedom, so that you could say over the whole spine, not each segment of it, but over the 6 segments of the spine involved, how much flexion, extension, left, right side bending, and axial rotation was involved, and so on. Now, could you have wearable technology that where all the segments talk to all the other segments and detected their relative alignment in 6 degrees of freedom in real time? Yeah, not today, but it's theoretically possible. And the continued explosion of technology may make it more feasible to capture skeletal alignment in real time. Major segments are one thing. You want to talk about the alignment of the kneecap within the groove in the femur that it resides, and that causes a lot of problems. That's another sucker, because even putting a marker on the skin isn't going to capture patellar alignment. You're going to need a bone pin with a cluster of markers on the end of it, and we're not going to do that in everyone practicing. So there are, technological or technical issues in quantitatively capturing skeletal alignment. Load distribution, which is very much related to skeletal alignment, but load distribution at joints, again, very difficult to capture, except in research laboratory settings with cadavers. You can, theorize them from or calculate them from models, but it's really pretty tough. Some of the models that go into that, and maybe this becomes more feasible in the future, if you have multi-channel electromyography, you can, using models of muscle force production and anatomy, calculate estimates of all the forces involved. Because when you do mocap, even with inverse dynamics, if you've got a force plate under somebody and you've got segmental motion capture, you're still only capturing the net moment of force at each joint from the kinematics, and you don't know how much co-activation of muscle went into that. So there may be a net extension moment at the knee, but it wasn't all quadriceps. Their hamstrings were active too, and the quadriceps were just overpowering them, so there was a net extension moment. But in terms of calculating in your model the joint reaction force, you've got to know about that co-activation. So, these are the problems of biomechanics. Trying to determine kinetics from kinematics is impossible. You need some measurement of kinetic variables, some measurements of force or estimates of force production. So EMG is a possibility. Electronic skeletal alignment sensors are a possibility, but it's a big mountain.
Right on. So Josh, hopefully that answers your question. If not, just chime in. I'm going to ask a follow-up question. So, in athlete development circles, targeting these movement technique issues is sort of happening through, the concepts of physical literacy and then increased youth strength and conditioning practices, and a real focus shifting away from physiological fitness more towards movement quality. What do you think the impact of that will be on injury rates in older, more, athletes with more training history, not necessarily just elite athletes, but athletes once they're older and this movement quality issue manifests?
Well, I think it's huge, Dave, as I think you could probably guess from my comments and my Sutton's Law slide. Movement technique in my opinion, and I think there's some evidence to support the statement, a critical determinant of the risk of injury. We know that a majority of non-contact ACL injuries are caused by a failure of skeletal alignment control. And we could get into theories, and you will, with Matt Jordan and others, about hip external rotator abductor group providing proximal control of the lower extremity alignment and so on and so forth. But this stuff is critical. And, there's some evidence, and I'll leave it to Ian to talk about how well cause has been demonstrated. But there's some evidence that teams that practice exercise programs such as those from Tim Hewitt or Ann Mickelbust, where they focus on hip muscular control of lower extremity alignment, lead to lower observed injury rates of ACLs in those teams. And when they stop doing the programs, the injury rates go back up. I mean, and
you're referring to like neuromuscular control?
Yeah, absolutely. And for me, it's all about the base, as Megan Trainor said. It's all about your ass muscles controlling. The most important knee muscles in your body are in your buttock. And by maintaining some activation of hip external rotators and abductors, you prevent your knee from deviating medially as seen in the frontal plane and sustaining valgus and axial rotational stresses that rupture the ACL. And I mean, we have a fair bit of confidence in a statement like that, notwithstanding arguments I get from Ian about demonstrated cause. But, we do it. I mean, everywhere in the world now, people practice these techniques, as you say, and I do think we implemented these ACL injury prevention programs in the early 2000s at U of T, and our observed rate of ACL injuries in the teams, we only had the money to do it in women's teams at risks. That was the politics of the situation. So with our women's soccer, field hockey, basketball, and volleyball teams, we send our staff physical therapist in twice a week, and they lead them through these ACL injury prevention exercises. And our injury rate over the last 20 years is half of what it was for the 15 years before that. Yeah. I mean, it doesn't prove anything. We didn't do it in a well-structured way to publish it as research, and other people have done that. But beyond ACLs, I mean, I do think that teaching movement quality, regardless of what it is, and it's extremely important in running, but it's extremely important in throwing, jumping. Like how you land is going to be a determinant of whether you get patella tendinopathy or jumper's knee. It's not just about the number of jumps and how high you jumped, it's about how well you land. And so that's not measured. We count volleyball teams' jumps, and they've got a little jump meter, and some they wear Vertex and whatever that are measuring their vertical jump and stuff like that. And so saying, well, you can only do 100 jumps per practice this week, and then next week you can do 105, and the week after that you can do 110. And that's all great because it's managing the rate of load progression and the rate of load quantity, which is an important variable, but it's not attending to how well they were landing.
Right. Yeah. Okay, so I'm going to ask another question. If anyone has questions, again, please jump in so we got one in the a couple in the chat now. So I'll let Chris Napier, if you want to just jump in and ask your question, please.
Sure. Hi, Doug.
Hi.
Great talk.
Thank you.
I'm a running biomechanics researcher, and so I know very well the difficulty with trying to determine, I guess, what are injurious biomechanics and the causal factors behind injury. How much do you think, I mean, I agree it would be nice to sort of say, okay, X and Y cause injury, and therefore, you are a runner with good form and less likely to get injured, and you're a runner with bad form and you're likely to get injured, we should change your form. How much do you think that individual variation plays in that, though? Because there are many examples of runners that you could look at who you could say have, quote unquote, bad form and should probably get injured. And you can take world-class runners and say that about them. And there's several I can think of off the top of my head. How much do you think people just adapt to their running form because they do it so much? And how much do you think capacity plays into that? Their ability to withstand those poor kinematics because they have enough strength and they've had enough training before that.
Well, the short answer is I think you hit multiple nails on the head there with that swing of the hammer, and I would agree with a lot of what you said. A lot of individual factors come into play, and I mean, whether someone who has what we would call objectively crummy form actually avoids, say, wearing out the cartilage on the back of their patella or the front of their femoral trochlea, or whether it's just that some people don't complain about it. I've had athletes who have no right to be walking who play professional basketball. They have no cartilage in either of their knees or ankles, bone on bone in 4 joints doing standing x-rays of lower extremities. And yet they're just a marvel to watch on the basketball court. And when you push them really hard, like, come on, is it stiff or sore? A little stiff in the morning, but I get up and get going, and okay. But objective measures, yeah, no, they've got an injury. They're not reporting it, but they certainly, the X-ray is an abnormal indicator, that's for sure. So there, and that's what you talk about. Some of them, are they able to adapt physically so that they actually avoid getting pathological anatomy in spite of what would seem to be bad form? Yeah, I'm sure we could come up with some examples where that might be possible because they adapt, or that their movement strategy to compensate. And so what we think would be a maldistributed load that would lead to tissue failure isn't, in fact, if you get deep into the kinetic weeds. But very often that individual variation is just their tolerance of their pathology.
Okay, great. So Chris, hopefully that answers your question. I'm going to move on to Adam to please ask the question that you posted in the chat form directly.
Yeah, great. Thanks, Dave. And great talk, Dr. Richards. As Dave said earlier, I've had the honor of listening to Dr. Richards give lectures at U of T and at the Canadian Sport Institute Ontario. So another fantastic lecture today. An extension of the first question that was asked, what are your thoughts on simple quantifications that can have an effect on the quality of movement? And what I mean by this is, I've worked with some practitioners who have tested range of motions using scales of 0 to 3 in some sports to help quantify quality of certain movements for particular sports. Is this type of data something that you think should be used more, or something that we should be moving away from?
No, I think we will move increasingly to quantifying all kinds of things. And the example you're giving using range of motion, so that's what I would call a kinematic variable. You're looking at any position, velocity, acceleration, jerk, those sorts of things. And quality of movement can be captured by some kinematic observations. The earlier example of skeletal alignment, that's a kinematic measure where you're not looking at the forces and moments, but just at what is the position of the body segments. So accurately capturing, people's technique. And I mean, professional teams will do this. Way back in the 1990s, I just was blown away when I saw Jimmy Andrews' office, quotes unquotes. Jimmy is God in Major League Baseball healthcare circles. He didn't invent, but perfected the Tommy John procedure and has done most of them on Major League Baseball players. He's down in Alabama. In his office, he has a pitcher's mound with a home plate 60 feet 6 inches away, and multiple cameras set up for mocap. And when he does a consultation with a pitcher, he's not just examining their sore elbow. I mean, he's got biomechanists who work with him, but they go into the next room and warm up, and they analyze, the quality of how this person is pitching, and they're using force plates and kinetics too. So they're really doing a full inverse dynamic analysis of their pitching. But even without the force plate, just looking at, for example, range of motion, how much does their shoulder externally rotate and horizontally abduct when they wind up, and what pattern of follow through do they have, and how much valgus excursion of the elbow is there at the middle point of the pitch, and so on. So those are things, and capturing kinematics is obviously technologically easier and will continue to explode. Intersegmental alignment was the challenge I threw out there, because it's more difficult than single point of mass measurements, like, a center of mass movement on GPS, or center of mass acceleration detecting jumps, and so on and so forth. But yeah, very real. And keep going, everybody, keep working on it. And because absolutely, information like that, detailed kinematic information that captures the details of how someone is moving in space, will lead eventually to, I think, a greater understanding of what is likely to cause risk of injury, or what is likely to be associated with risk. Gotta watch that word cause. Is Ian still on the line? Anyway, okay.
Yes, he's still lurking. Great. Okay, so just for the sake, so we're at 11:15 right now. I'm happy if Doug is to stay on the line for another 10, 15 minutes or so. But I think I'm going to stop the recording now, unless there's any other pressing questions. And then those who want to take off can do so, and those who want to stick around to chat can do so as well, as long as, again, Dr. Richards, you're okay with that.
Sure.
So if there's no other pressing questions that you want to be part of the recording, then I'm going to stop it. So I'll give you about 5 seconds or so to chime in. Okay. So I want to thank Dr. Richards again for a really excellent talk. And it's a profound, I really enjoyed, hearing, the quality of the data collection really does matter. And so, as analysts, we'll get a data set and, go to town on it, I suppose. But, obviously analyzing all the philosophical issues underlying those data are, absolutely critical. So thanks a lot for pointing all those issues out with respect to injury quantification. Thanks again, Dr. Richards.
My pleasure. Thanks for having me, Dave.
Okay.